Welcome back to my channel. So today we'll be discussing the ankle joint complex, which is a complex because we have three joints participating: the distal tibiofibular, the talocrural, and the subtalar joint. The talocrural is formed between the talus, the malleoli, and the tibial plafond. The subtalar joint is the steering wheel of the body, and it's formed by the calcaneus and the talus. So this is the ankle joint proper, or what we call the talocrural joint, because the dome of the talus or the trochlear of the talus will articulate there. And then you have the crura, which is the leg. So the bones of the leg, you have the fibula giving you the lateral malleolus, and the tibia giving you the plafond or the distal articulating facet, and the medial malleolus. So we classify that talocrural joint as a synovial joint of mortise and tenon variety, and this is because of the bracket-shaped socket here. You can be able to see the medial malleolus, tibial plafond, lateral malleolus, and this forms the mortise. And then you have the talus forming the tenon. The distal tibiofibular joint, we classify it as a syndesmosis. Now the subtalar joint is basically this area here, which is formed by the flat surface of the calcaneus above, and then you have below the talus some flat surface, and that is why it's known as planar variety. So it's a synovial joint of planar variety. So the stability factors are divided to static and dynamic, and the dynamic factors are the extrinsic muscles of the foot. By extrinsic, we mean muscles that originate on the leg and insert on the foot. So the talocrural joint, the most important static factor is the distal lower extremity syndesmosis, while for the subtalar joint will be the deltoid ligament and the lateral complex. The deltoid ligament is a medial ligament, so it helps to prevent hypereversion, while the lateral complex is a lateral ligament, so it helps to prevent hyperinversion. So hypereversion is excessive lateral movement, so it's prevented by a medially placed ligament, while hyperinversion is an excessive medial movement of the foot, which is prevented by lateral ligaments. So this is the distal lower extremity syndesmosis, and the reason why it's the most important stability factor of the talocrural joint is because it's the one that maintains the socket. It maintains the mortise. So you have the interosseous ligament and the interosseous membrane maintaining the connection between the distal tibia and the distal fibula, and becomes the most important stability factor. An injury to the interosseous ligament and the interosseous membrane will ensure that you don't have a mortise. This is the lateral complex. You can be able to see the anterior talofibular, calcaneofibular, and the posterior talofibular. Posterior talofibular inserts on the malleolar fossa, which is important in siding the fibula because this fossa is considered to be inferior, posterior, and medial. And so you can always use this fossa to side the fibula. The deltoid ligament is a medially placed ligament with three strong bands, and so it rarely tears whenever you have hypereversion. Most of the time you'll get a avulsion fracture of the medial malleolus. The most important stability factors with regards to the subtalar joint inferiorly will be the spring ligament or the plantar calcaneonavicular ligament, which prevents inferior displacement of the head of the talus whenever you have weight bearing occurring. So you have the dynamic stability factors here. These are the extrinsic muscles of the foot. So they originate from the leg and they insert on the foot. And so this will form the dynamic stability factor. So remember, muscles coming from the anterior compartment, posterior compartment, and the lateral compartment of the leg. When it comes to the neuro supply of the ankle joint, remember Hilton's law. So we'll have articular branches from the deep peroneal nerve, which innervates the anterior compartment of the leg, the tibial nerve, which innervates the posterior compartment of the leg, and the superficial peroneal, which innervates the lateral compartment of the leg. This is the vascular supply, which is formed by the talocrural anastomosis. So remember, the anterior tibial will give you medial malleolar branches, the posterior tibial will give you medial malleolar branches, and so they will tend to anastomose. Then you have the perforating branches of peroneal artery, and the final perforating branches will form part of the anastomosis around the ankle joint. When it comes to the clinical correlates, there are three types of fractures that you can be conversant with at this point. One of them is the Danis Weber classification, which basically looks at fractures of the fibula in relation to the syndesmosis. So remember, what you have is the syndesmosis at this point here, the distal tibiofibular syndesmosis. And so if you are below the syndesmosis, that is type A. If you are above the if you are at the level of the syndesmosis, that is type B. And if you are above the syndesmosis, that is type C. And so these are what we call the Pilon fractures. These are fractures of the tibial plafond. And so based on the number of parts that are injured, then you can have different levels of classifications. This is what we call a trimalleolar fracture, when you have the lateral, the medial, and the posterior malleolus. Posterior malleolus is the posterior surface of the tibial plafond. So when all these three are fractured, we call that a cotton or a trimalleolar fracture. On to the multiple choice questions. The most important factor in maintaining the integrity of the ankle mortise is the distal lower extremity syndesmosis. A construction worker falls with feet first, has a fracture of the groove on the undersurface of the sustentaculum tali. The tendon likely torn will be the flexor lucis longus. Remember, sustentaculum tali is basically a hard name, just meaning that this is the part of the calcaneus that sustains the talus. So it's a medial shelf of bone on which you have the talus being supported inferiorly. So below that sustentaculum tali, you have the tendon of the flexor lucis longus passing there. The following statement is true regarding the talus. The body receives a retrograde pattern of blood supply. This is true. Remember, the talus receives blood from the vessels coming through the neck of the talus, and then it passes from distal to proximal. So natural anterograde supply is proximal to distal, and so if you have blood supply coming from distal to proximal, we call that retrograde. The following movement of the ankle makes you stand on your heel, and that will be dorsiflexion. If the question was the following movement makes you stand on your toes, then the answer will be plantarflexion. So the bone A is the navicular. So this is the bone that articulates with the talus anteriorly. And so the joints that are formed here, the most important one is the mid-tarsal joint here. So the mid-tarsal joint is the most important joint. But you also have talonavicular joints. And so usually here what you have is a complex joint between the talus, the calcaneus, and the navicular. And we call that joint the acetabulum pedis. The acetabulum pedis. And so remember also, you have the mid-tarsal joint. Two intrinsic muscles in the deepest layer of the foot and the innervation. So the deepest layer of the foot has the interossei muscles, the dorsal and the plantar interossei. Those are intrinsic muscles, and they're innervated by the lateral plantar nerve. So this is a real life photograph showing you the talus. And so the stability factors, static stability factors of the ankle joint, remember the distal lower extremity syndesmosis, the deltoid ligament, the lateral complex of ligaments, and then you can talk about the interosseous ligaments or the spring ligaments. So when you break down the lateral complex of ligaments, you get three ligaments: calcaneofibular, anterior talofibular, posterior talofibular. Then you have the deltoid ligament. Then you have the distal extremity syndesmosis, and then now you have the interosseous ligament. The interosseous ligament is a ligament that is found within what we call the sinus tarsi. Okay, the sinus tarsi. It's a space formed below the talus and above the calcaneus. It's a space between the talus and the calcaneus. The part of the bone being pointed by the forceps is this, and this is the medial malleolus. The ligament that attaches there is the deltoid ligament. Dynamic stability factors of the ankle joint, you can name any muscle from any of the compartments. Remember, from the anterior compartment, you have the dorsiflexus. From the lateral compartment, you have the everters, and the posterior compartment, you have the plantarflexus. So you can talk about the peroneus longus and brevis from the lateral compartment. You have the tibialis anterior, your extensor digitorum, your extensor hallucis from the anterior. Also you have the tibialis posterior, you have the flexor digitorum longus, flexor hallucis longus from the posterior compartment. So any of the muscles from the compartments of the leg will be dynamic stability factors of the ankle joint. So this is the final slide. If there are any questions, you can leave the questions on the comment section below. Thank you for your attention.